I'm going to talk to you about infection control and where we've got to, because this has been a massive journey, and the journey is not finished yet. The MRSA and C. diff was part one. The E. coli is going to be part two, or gram-negative bacteremias, if I may be correct. And then obviously, some of you will have experienced something called CRE, and that's graduating to the next phase, which is the toughest level. So let's just go on this journey now. The key things here are better practice, better outcomes, and safer healthcare. The views I say, because I work for Public Health England, what I say is my personal opinions. They're not PHE policy or DH policy either. People need to have a vision. To go forward, you certainly need a vision and you need an aim. And there was a vision for MRSA and there was a vision for C. diff. You may recall some of my previous presentations where I had the minister. And the minister proclaimed a 50% reduction in MRSA bacteremias within 3 or 4 years. And that 50% reduction in MRSA bacteremias was achieved. But it wasn't achieved straight away, because in the first year, everybody scratched their heads and said, who advised the minister to have a 50% reduction in MRSA bacteremia? It cannot possibly be done. Now, I can see in the audience that a lot of you are very young. You may not even have seen the picture of the minister or even heard the announcement to say that this was the aim, but it was. That was the aim. And there was disbelief because people thought it couldn't be done. So how many of you think that the gram-negative bacteremia that you've heard about this morning is not going to be achieved? Hands up. Well, NHS improvement, and Elizabeth is sitting there because she's been tweeting all morning, and she's tweeting this afternoon, and there's no hands up. You all believe. And that's the really first conclusive thing that you need, is that you've got to believe that you can break that 100-meter sprint, or you can break the 4-minute mile. I have different slides for these concepts. But this is really important because that's this very great starting position. Elizabeth, you're on a winner. Absolutely. So we have to have a vision. And when President Kennedy had that vision, and you might have seen the YouTube clip or the NASA clip, to say, we will put a man on the moon before the decade is out, that's what the story's about, and that's a vision from the last century. And when we talk about improvement, this is a Saturn V rocket. And the improvement on this was that this bit wasn't there on the first Apollo. You know what happened? Anyone know what happened? There was an explosion down below, here, and 3 astronauts in the first Saturn V launch burnt to death. They couldn't get out. And so this little rocket had to be put on. There was an improvement. This little rocket had to be put on. If anything happened down below, that rocket would ignite, and they take the capsule with them with the 3 astronauts in. And then you know the rest of the story about going to the moon and walking on the moon. So this is the beginnings of infection prevention control. Lots of you will have heard the story of Florence Qatari Hospital. She got sent out there by, I think it was either the Minister for Defence or War, and he said, Florence, would you like to please go out there because there weren't sanitary conditions. That's a story to be read. We always learn from the past, and this is something to learn of what she was. She would have had an honorary epidemiological degree as well, because she's actually produced statistics. There's papers of statistics that she wrote. Joseph Lister, antiseptics. And you can see this, you'll see this because we've got a big screen. Sorry the pointer's not working, but at the bottom of his right hand, you will see the glass flask for the carbolic acid that he used to spray. He achieved a reduction in surgical site infections. Susan talked about surgical site infections. And then obviously Semmelweis, who didn't have a very good ending, but knew that there was infection about because the medical students where he worked used to do the post-mortems and then went straight into the labor ward without washing their hands. And he put a little sheep dip outside the maternity ward to say, you will do a sheep dip before you go into the obstetrics. And he cut down puerperal sepsis and ladies dying because of people's hands had not been cleaned. These are stories that are worth telling. Anybody in the audience that remembers this and this report? Hands up, or who's read the report? There's about 10 hands up in a room of 370, which Paul said to me that was in the audience. 1984, which is where our journey starts, psychogeriatric hospital, 788 residents. Talk about care in the community. 788 residents. This was the worst ever recorded hospital outbreak in the UK. Read the report, read the story, read Hansard, Baroness Trumpington, I think it was, on this one. Residents ate on a Saturday evening. The first one became ill on 7 a.m. on Sunday morning. 9:15, there was 36 ill. 9:15 p.m., there were 94 ill. And the first one died at 11:35 just after 24 hours. There were a total of 19 deaths. This was a shock to the system because the public health system, the medical health officers, etc., were different. In those days, it was configured in a different way. But you can see in the other column the number of staff that were ill and affected. And look at the row which says asymptomatic stool positives. We don't do asymptomatic stool testing, but look at that when it was done. Do you remember this next outbreak, the 10 people that put their hands up? These are things that you have to read to appreciate what went on and how these were investigated and put together and what control measures they put in. This was the Stafford District General Hospital. The report was published. On the bottom left, I put the reference so you can actually read it. And the Hansard on this was equally good. I'm sorry that the typhimurium slide is there. That's an error. I've forgotten to change that. But you can see that an estimated 68 confirmed cases were treated for Legionnaire's disease. 22 of these patients died. There were a further 35, 14 of them were treated at home for Legionnaire's disease. All of the patients had visited the hospital during April 85. The key thing was that when, and we did antibodies in those days, tested the staff for antibodies, a third of the staff had antibodies for Legionella. That means they had been exposed, but being champion healthcare workers, they ploughed back into work and ignored their symptoms and were still working through either Pontiac fever or a mild asymptomatic or slightly symptomatic Legionnaire's disease. So obviously with 84 and 85, the Department of Health and the powers that be had to do something. And the first paper that was produced was this Fennec paper that was published in 1985, by Haley, who said a third of nosocomial infections can be prevented. A third. What do we know now? How many MRSA bacteremias can be prevented? If we talk about zero tolerance, all of them could be, but about 95% or so could be prevented and done. Look at the reductions in C. diff that we've seen. They're above a third, so a significantly higher number of those infections can be prevented. So the Department of Health then organized this working group, a hospital infection working group, and the guidance was issued, and it was Mary Cook's report. This was the health circular. I can't find it on the intranet, and it's not in the DH archives either. But this was guidance for the first time for infection prevention control in hospitals. And then there was further guidance issued in 1995 when that was a real claim to say hospital-acquired infections can be prevented by could be avoided by better applications of the existing knowledge and realistic infection prevention control. This might be hand hygiene. This might be all the interventions that we've learned in the last decade and a half of MRSA and C. diff and all of the documents that were published. So this was the executive letter now, and this was what was issued for hospital infection control, and community infection control came in afterwards. But this was a recommendation to purchasers of healthcare, so this would mean NHSE and the CCGs, to say there was a contractual requirement for surveillance, infection prevention and control. And routine surveillance was, and things that we do as a mandatory, and things that you do as a voluntary reporting, and including non-outbreak associated infections. And the recommended arrangements for the control of outbreaks and the response to major outbreaks in the community. This is taking the Stanley Royd into account at this stage. So, the journey that we had, where were we and what have we traveled? So, winning ways. There was a publication every 6 months, basically. If you remember these documents, they are still there and alive. Winning Ways, 2003, towards cleaner hospitals. You'll remember the headlines, dirty hospitals. I'm not going into a dirty hospital. The Matron's Charter, empowering nurses, saving lives, and the start of it was getting ahead of the curve when the Health Protection Agency was formed. The key thing I want to say out of those historical documents, the Health Protection Agency published a paper on MRSA mortality, if you remember. And you saw from Susan's data this morning that out of the nearly 900 or so bacteremias that we have, around just over 200 patients die of MRSA bacteremia, still die of MRSA bacteremia. Around 2,000 patients die of Clostridium difficile. I'll be doing another talk in 2 days' time. Talking about C. diff mortality. So this is mortality, 30-day all-cause mortality for MRSA, and we've got to see if we can actually improve that, and I don't know why the female death rate has gone up. We need to look at that in more detail to see what the reason is. And this is 30-day all-cause mortality for Clostridium difficile, and these are the dotted lines and the continuous lines. That's for 2 to 14-year-olds. The next one is 15 to 45-year-olds, and it goes up. And you can see the marked difference in mortality that we've made for 65 and over and the 75-year-olds. But the mortality above 85-year-old is still very high. So for C. diff, there is still unfinished business, is that we've still got a number of cases that at the moment are classified as community, but they do have a hospital link, and that it's the severity of disease that we need to look at. And those people with severe disease, have we treated them properly? We need to look at the recurrence and recrudescence rates, and we need to look at the mortality for C. diff and to see if we can improve in those areas. So that's the message from this slide. But we graduate, and I'm going beyond the gram-negative sepsis, to these issues that are facing London at the moment, and apologize to those that have come from outside London. But as with MRSA and as with C. diff, these are things that you will see in the future, but London is seeing now. These are the 5 main mechanisms for carbapenem resistance. There are a lot more, which I've put on the slide in the bottom right-hand corner. But these are the 5 main mechanisms. And the size of the text in red gives you an impression of how big they are. And the OXA is the biggest mechanism in London. The next is NDM, followed by VIM, KPCs, and IMPs. In London, we're holding a CRE workshop tomorrow afternoon, and if you need details of that, then you can see me afterwards if you're from London. But there are other ways that carbapenem resistant can be expressed, which we won't go into. But these are infections. At the moment, they're colonizations with some infections, bacteremia and urine infections. But these are infections that we can not treat with our meropenem, which is the most powerful drug that I can use in A&E to save a patient's life. These are multi-resistant, and the only things that are sensitive are colistin and tigecycline. And the microbiologists won't need reminding of that, but other colleagues, we do have some antibiotics that we can treat these organisms with, but resistance to colistin is already being seen and is being expressed. Not only do we have the 5 main mechanisms, and I've only put 4 around there because that circle could only hold 4, but you can see that if you had that mechanism, it could go with E. coli, Klebsiella, Enterobacter, Citrobacter, and any of the Enterobacteriaceae. For the VIMs, you could have it that way round, and you could have OXAs in this way round, and the NDMs in that way round. MRSA, we were just dealing with eMRSA 15 and 16. You have got to start to think in 3-dimensional ways, and these are not chromosomally based, these are plasmid based. So that if a patient had an E. coli KPC inside their gut, they could just donate that KPC to a Klebsiella or an Enterobacter in their gut. Do you see how we're actually expanding this into a 3-dimensional model? And this is how complex these infections are now getting. Not only that, but eMRSA 15 and eMRSA 16 were clonal. So it would be a clonal spread that would be moving along. So we have these combinations, but with these combinations, if you had a Klebsiella pneumoniae ST258, which is a very successful global clone, then you can imagine that complexity moving faster because that's a successful hospital-adapted or human-adapted clone that would move forward. We have the same with ST111. We've seen in Pseudomonas aeruginosa, that clone, and Klebsiella pneumoniae ST14. Susan mentioned the point prevalence survey. It's not changed, but we're talking in England about a figure of 8.2% and in 2006 and 6.4% in 2011. So let's see what that similar figure is like. But at the bottom of there, I've put down what the highest HCAIs were associated with that. So pneumonia, UTI, SSI, because that was the first time pneumonia was higher than UTIs. I had to participate in the neonates with neonatal bacteremias for Pseudomonas aeruginosa in Northern Ireland. And that's the reason why I've put this up, is that infection prevention control now, we've heard about the water committees, you've got to have a water champion, you've got to have a safety committee. So it's got complex. We've got decontamination committees. We've got endoscopy committees as well. And so the complexity in infection prevention control has expanded enormously to what we thought was just sort of hand hygiene and environmental cleaning. And these are the people that these bacteremia seem to take away. They're very young. I was just having a word with Sarah Mumford about the neonates and sepsis. And these are the elderly that these septicemias and bacteremias take away. And it's true for E. coli. It's the same graph, but it's 35,000. And it's the same for Klebsiella at 5,000. So, nearly finished, but my key message is that over the decade and a half, we've got to a particular level of hand hygiene. But that hand hygiene is not translated into sustainable behavior. Humans still make mistakes, and people still have to be reminded about hand hygiene. They still have to be reminded every time about misuse of gloves, because they put the glove on and they've got contaminated gloves and they walk around with those gloves because they seem to protect themselves but not others. And they contaminate the inanimate objects, and that's where the next person will pick it up and put it onto a patient. So we have to enormously improve our hand hygiene, and it's got to be practice, good practice, every single day, every single time. And if we don't do that, we won't be able to control CRE. In America, when they had outbreaks, they pushed their hand hygiene practice up to 100% compliance. And that's how they achieved control. And this is where we will need to be in future and in future outbreaks. The next big issue is environmental cleaning. And I haven't got time to go into this in detail, but you all know about frequently touched areas. And what we're now learning from gram-negative outbreaks and with CRE outbreaks is that the environment around the patient gets contaminated. And that this is why, and one paper that I'll be producing, showing tomorrow, shows that they actually cleaned up the place around the patient 3 times a day to keep the lid on the infection spreading out and going to other patients. Deep cleaning and terminal cleaning, again, we're graduating to modern technologies, because some of the deep cleans where it's sort of human-related are not sufficiently good for safeguarding the next patient that gets into the room. Peter Wilson, if he was here, normally says that about 30% of the horizontal surfaces do not get cleaned in a deep clean. You put the next patient in and they acquire the CRE that the previous patient had. And we see this so often that that room needs to be really clean. So detergent-based and chlorine-based usage has gone up in the appropriate way, advised by Infection Prevention Control. And now we have the newer technologies for the vapors and the mists and the UV light. And again, there's a science behind that to say what is the most appropriate. Just as there's the science behind, is it a detergent wipe? Is it a chlorine-based wipe? Does it kill spores? There's a science behind these new technologies that we will need to learn to say, are we doing it appropriately? If I asked how many of you have conducted a mattress audit in the last year, just the acute hospitals, but again, we could go to care homes and the rest. There are things that we've forgotten in this journey that we used to do previously that we don't do anymore. And again, are we perfected in our infection prevention control? And that's going to be the key issue in the coming months and years, to make sure that we don't become endemic. We've lost the bit on the ESBLs, because that was a decade that we missed out on. But we cannot lose the control for CREs because there are no more antibiotics, and we will have to implement infection prevention control in a really strong way to affect the achievements that we want to get to. Device management. To prevent CRE bacteremias and to prevent gram-negative bacteremias, the high-impact interventions, you remember there were 1 to 8, those will need to be revived and put back, and the bundles will need to be resurrected, and to make sure that everybody is aware that these are the issues that we need to get to an optimized level for these controls. So thank you very much for listening to me, and I hope that you will take these messages back, because that's what we need to halt CRE infections.